Hello, my name is Deborah Dias. I'm a PhD candidate at the State University of Maringá, Brazil. It is my great honor to participate in the 33rd annual session of the International Society of Periodontal Plastic Surgeons. Today, my topic will be immediate implant placement at maxillary central incisor sites, an updated 10 keys concept. You might be asking yourselves, why maxillary central incisors? Well, I can tell you a few reasons to consider these sites so special. First of all, of course, they're the most important site on aesthetics. They're close to the midline where symmetry matters the most. Minor alterations can and will be perceived there. Secondly, following tooth extraction, the alveolar socket is a four-wall bone defect. And on these sides, this defect is wide with a thin buccal bone, which is quite different from premolars, for example, that presents narrower defects with a thicker buccal bone. Okay, but how thin is the buccal bone on maxillary central incisors? Studies have shown that it is about 0.6 millimeters thick at 3 millimeters below the bone crest. Okay, keep that number. But the alveolar socket is not a common four-wall bone defect. It is special because it is made of two types of bone. Let's see a histological section. From your left to your right, you'll see the dentin, then the cementum, the periodontal ligament, and the buccal bone wall that presents the bundle bone and the alveolar bone. The bundle bone is the bone that faces the root surface, and it is nothing but mineralized periodontal ligament, totally tooth dependent. When the buccal bone is too thin, as in this histological image, its entire thickness might be made of bundle bone. And the issue here is that following tooth extraction, this is a tooth-dependent structure, this will disappear. Thus, treating sites like maxillary central incisors is a challenging situation. And over the past years, immediate implant placement in the aesthetic area was a synonym of aesthetic failure, of aesthetic complications, for example, of mucosal recession. But let's try to understand it. When you think about immediate implant placement, what comes to your mind? I believe you think about having enough bone to ensure primary stability, placing your implant in an optimal 3D positioning, and having an intact socket wall, an intact buccal bone wall, right? But is this knowledge of the anatomy of the alveolar process enough to achieve predictable outcomes? The answer is no, it isn't. Previous studies have used this criteria as inclusion criteria for their studies and reported unpredictable outcomes. They even suggested that caution is required, that immediate implant placement should not be recommended when aesthetics are important. And these two case scenarios might illustrate it. They do have intact socket walls, available bone, apical and lingual to the socket. However, the bone anatomy is completely different between these two sides. To your left, the alveolar process is narrower, the buccal bone is thinner. Probably most of this buccal bone will be bundle bone and will soon disappear. And even the basal bone is different. It could explain why the results in the literature have a wide range of outcomes. Taking into consideration the challenges of immediate implant placement on the aesthetic area, Dr. Robert Levine and his co-workers proposed the 10 keys protocol, aiming at helping clinicians to achieve predictable outcomes. It has 2 planning keys, 5 surgical and 3 prosthetic ones. The planning keys are aesthetic risk assessment and tomographic plan. The surgical keys include a minimally traumatic tooth extraction, followed by implant placement in an optimal 3D position, allowing space to place your biomaterial there, your low substitution bone graft, between the implant and the buccal bone, and finally placing a connective tissue graft in the buccal aspect. But today we're not going to talk about the surgical or prosthetic keys. Let's focus on the treatment planning ones. So let's begin with the static risk assessment. Here, it is important to align the case complexities, such as a high smile line, a thin gingival phenotype, with the patient's expectations. Nowadays, patients want symmetry, a perfect outcome. So this is important to see the limitations of each case. And we use it in all static cases that we perform. Then there is the tomographic planning. And as I told you before, of course, you consider those anatomical factors. For example, the achieving primary stability, placing your implant in an optimal 3D positioning, and selecting sockets with an intact buccal bone. But I would like to present now our latest studies on this matter. Some factors that you should also evaluate when planning immediate implant placement. Our first study aimed at describing the anatomical predictors for successful ridge preservation with immediate implant placement. 25 implants at maxillary central incisors and 25 contralateral tooth sites were evaluated. All implant sites underwent the same intervention: minimally invasive tooth extraction, implant placement, and socket grafting. Then, after about 5 years in function, a CBCT scan was obtained. And we compared the cross-sectional images of the control sites, that is, the tooth site, with the ones of the implant ridge, to evaluate the dimensional changes that had occurred. And it was impressive that we observed two different outcomes. Some implant ridges, as to your left, presented a significant reduction, while others, to your right, seemed preserved. And this is shown in this frequency distribution. The implant ridge lost in average 25% of its pristine dimension when compared to the tooth side, but there was great variation. That is, some sites presented a huge reduction, while others seemed successfully preserved. So, we built a linear regression model having this reduction of the alveolar process area as the dependent variable. And let's see which factors promoted better ridge preservation. First of all, the thicker the buccal bone at 3 millimeters from the crest, the less the ridge resorption. Secondly, the wider the alveolar process at the same level, the less the ridge resorption. That means better ridge preservation. The tooth angulation in relation to the alveolar process seemed to impair the results. As you can see, the blue line represents the alveolar process angulation, while the yellow one represents the tooth angulation. And sites in which the tooth seemed outside the alveolar process were at risk to present worse outcomes, as you can see to your left. And finally, the gap dimension. The gap is the distance between the implant shoulder and the inner aspect of the buccal bone wall. The wider the gap, the less the ridge resorption. And to each additional millimeter the gap was increased, there was about 17% less reduction. Thus, we can conclude that the morphology of the alveolar process is fundamental for successful ridge preservation with immediate implant placement. Okay, but then we got curious. What is the ideal size of the gap? Is there a reference level that we could use? So, in this study, with the same design, we had the implant site and the contralateral tooth as control. We split now the sample according to the dimension of the gap. The gap was measured during surgery, following immediate implant placement. And now we have these two groups. The wide gap group, in which the gap was greater than 2 millimeters, and the narrow gap, in which this distance was 2 millimeters or less. And these are some examples that we included, and we have the tooth site and the implant ridge. Let's see what happened. This table will show you the overall alterations between the pristine alveolar process, the tooth site, and the implant ridge after some years in function, about 5 years in function. So as you can see here, the total cross-sectional area in the wide gap showed minor reduction. It was less than 10%, or 8.8, which is quite similar to previous studies reporting the ridge preservation alone. While in the narrow gap, a significant modeling was observed. 41% of the ridge was reduced. Thus, this study showed that a buccal gap greater than 2 millimeters is able to preserve more than 90% of the ridge dimension. And now we decided to evaluate the effect of the gap dimension, not only in the ridge preservation, but on the newly formed buccal bone wall. Taking into consideration all changes that occurs in the alveolar process after tooth extraction, leading to marked changes, we want to avoid complications. We want to see a stable buccal bone wall at the 10 years follow-up, for example. So here we were able to increase our sample. Now we had 51 implants placed at maxillary center incisors following the same surgical procedure and having the same two groups, gap greater than 2 millimeters and gap of 2 millimeters or less, wide and narrow gap. Let's take a look at the thickness of the buccal bone at the implant shoulder, 2, 4, and 6 millimeters below. It was significantly thicker in the wide group in the gap greater than 2 millimeters at all levels observed, and the difference was more than 1 millimeter at all levels. Okay, so far we know wide gap, thicker buccal bone. What about the buccal bone height? That means, what about the percentage of the implant, the buccal aspect of the implant that is covered by bone? As you can see in this frequency distribution. In the narrow gap group in blue, the majority of the cases presented less than 50% of the implant height covered by bone. While in the wide group in orange, the majority of the cases presented more than 80% of the buccal aspect of the implant covered by bone. Thus, in conclusion, this study showed that the wide gap, the greater than 2 millimeters gap, promoted a stable, thicker, and higher buccal bone wall. And now I'll come back to those two different case scenarios that I showed in the beginning of the presentation. Let's use a planning software. Here we're using Co-Diagnostics. So we first align their DICOM and STL files, and let's plan the same implant dimension for both cases, following, of course, an optimal 3D positioning. Now let's do some mathematics. To your left, we have an alveolar process with a 7 millimeter width, while to your right, it is 9 millimeters. The buccal and palatal bones are also thicker to your right. The tooth is outside the bone envelope to your left, while it is totally inside to your right. Yeah, to your right. So let's take a look now at the implant when we place the same implant in the two cases. A narrow diameter tapered implant, 12 millimeters long. As you can see to your left, there is not enough bone to place this implant. Even though we have intact socket walls, we don't have enough bone here. This should not be recommended. While to your right, we have enough bone to place a narrow diameter implant, but we also have enough bone to place a regular diameter implant if you'd like, because the anatomy would allow a gap wider than 2 millimeters, it would be there. So it seems clear that only one of these cases should be considered for immediate implant placement. The one to your right. This is the case that will offer you predictability. And that's our updated 10 keys concept. Our research gave you information so you can have predictable outcomes following immediate implant placement. What do you have to do? You need to study your CBCT scan. Besides those three conventional items that we consider, let's evaluate if the tooth is inside or outside the bone envelope. Let's check if the width of the alveolar process is enough, and perform a careful implant selection, allowing for a greater than 2 millimeters wide gap, and place your lobe substitution bone material there. Thus, my take-home message is case selection. Ridge preservation and immediate implant placement can successfully preserve the ridge dimension if you consider the anatomy of the alveolar process and the size of the gap. The 10 keys must help you selecting those cases. Finally, I would like to thank all the members from my research group in Maringá and our 10 keys team, especially Professor Robert Levine, Professor Mauricio Araújo, and my dear colleague Ping Wang. Thank you so much for your kind attention.